at Monash University and the Florey Institute. My role is Executive Director of the Australian Stroke Clinical Registry, and in terms of the Centre for Research Excellence in Innovation and Translation in Stroke Trials, I'm one of the chief investigators with responsibility for the Workstream on learning health systems with Caleb Ferguson and Sandy Middleton. And my colleague Bola Fasugba from Australian Catholic University is also here. Bola, will you introduce yourself?
Yeah, thanks, Dominique. So my name is Bola. I am a senior research officer at the Nursing Research Institute, and I work with Professor Sandy Middleton on the QASC research program. Thanks.
Okay. And Elizabeth Lynch is also with us from Flinders University, and she will be facilitating questions and answers at the end of our presentation. So I think without further ado, we've got 19 people logged in. I will start off, and I will first open the meeting by an acknowledgement of country. I'm on the lands of the Wurundjeri people of the Kulin Nations, and I just, in the spirit of reconciliation, recognise the traditional owners of the lands in which we're meeting from wherever you are, and pay our respects to elders past, present and emerging. And I also wish to acknowledge the experiences and valued contributions of people that have the courage to share their unique perspectives with us to improve better outcomes for all. So that is people with lived experience that are involved in our projects and programs. So my work in learning health systems has really been to try and unpack that and provide the story around learning health systems and the role in stroke. If I have a QR code on a slide, that is a publication that you can go to for further information. And the idea behind learning health systems is that it uses real-world data that is collected and used by clinicians or health service providers to inform their clinical decisions. And it's different ways of having data summarised for real-world research and to allow for iterative improvements in care delivery through data-driven approaches. This can include specific research projects that you might tie within a learning health system to advance health systems or improve the quality of care in hospitals. So you're going to learn about a number of different terms that we use. Some of these are interchangeable, but just keep in mind that what we are talking about is how in the real world we get best practice care delivered, and we can undertake different types of research, including what comes under the banner of implementation research, to optimise the way in which we do that, or to better understand strategies or design features of, you know, even the way we deliver a dashboard, for example, that is effective at driving system improvement or clinician behaviour change. So that's the main reference for that. So one of our key infrastructure pieces in Australia for learning health systems is having the Australian Stroke Clinical Registry in place, and that's led by a consortium of the Florey, Monash University Stroke Foundation and the Australian New Zealand Stroke Organisation. At the moment, we have 71 active hospitals across 7 states and territories. We use an opt-out approach, so we avoid responder bias, so people are included in the registry unless they request to not be in the registry. We collect data on approximately 20,000 acute stroke admissions each year, and we've completed follow-up on over 80,000 people who complete a patient-reported outcome survey within 3 to 6 months after their stroke. And our platform, which is the Australian Stroke Data Tool, has over 400 users, and some of those include people that have collected data for the Stroke Foundation audit program. That stopped last year, but we are looking at how we can support some of those hospitals to come on and use the registry platform to collect data and be part of the wider OSCAR program. So the key objective of the registry is really to support a continuous learning culture where we have clinical guidelines that provide the evidence for what we should deliver in clinical care, and then knowing that there are lots of challenges in doing that. There are, you know, patient level factors, clinical factors, system factors that can influence that. By feeding back data, clinical teams can look at areas where they're doing well, but also where they're doing less well, and then can work to develop, you know, strategies to address the barriers that are modifiable within their health system. How we support people to understand their data and know where they sit relative to others is through having interactive dashboards that summarise data and refresh every night, and they have a number of filters, so they can filter by age and gender, for example, or stroke type. We also provide a scorecard and a detailed performance report each year, as well as publish an annual report. Hospitals can download their data at any time and do further interrogation, and they can also access the follow-up data from their patients. And we also publish articles to inform the field about stroke care, all registry science. One of the key contributions of OSCAR and, you know, the utility of the data is that we ask people who are alive and complete the survey if they are wanting to be contacted for further research studies. So that, and another way we've future-proofed the registry is by telling people in the information sheet that we can link or will link their data with other hospital or health information systems. So what this really means is that we can enrich the minimum data that we have in the registry about individual patients and not ask clinicians to collect more manual, you know, do more manual data collection. And since 2011, we've had 61 research projects that have used the Australian Stroke Clinical Registry data, or have come to us to recruit participants through the OSCAR. And I'll provide a couple of examples of that. But you know, the big overview of where we've come from and where we are now is that we started with a very small project in 2008 and 2009, and then we're able to obtain a partnership grant with Queensland Government providing some funding, which allowed us to have statewide uptake. But then in parallel, we were establishing data linkage projects in different areas, starting with death registrations. And these all have been bespoke one-off linkages, but they've given us greater insights into patient journeys, what has happened to people before stroke, what's happening after they leave hospitals, how often are they adhering to their secondary prevention medication, for example. We're very grateful to finally receive Commonwealth funding through their Clinical Quality Registry program, and that's been awarded for 3 years. And one of our objectives is that we will need to have a single partnership agreement with state governments and the Commonwealth to continue the registry into the future, and that will hardwire it into the Australian health system. So that's one of our jobs. So we've really used the data to understand how to improve registries. So this is all about it, you know, learning health system approaches can happen in any organisation, and even within the organisation of a clinical quality registry program, you want to be able to optimise and use the data that you're obtaining to make sure the registry is always current and delivering what it needs to deliver. So these are just some examples of where we've undertaken registry-based projects to improve what we offer as part of the registry. In terms of the broader CRE program, where this all fits is that there's innovation happening and rapid translation as part of our objectives that would feed into the Stroke Living Guidelines programs. And then we have this shared information environment, whether that's using data from state and territory or stroke networks within the national platform. And although the Stroke Foundation audit has been discontinued, data can be requested. If people have research questions and there are data sitting there that have been archived, you can put in a request to analyse that data and work with the Stroke Foundation or with the registry program. So I'll tell you how you can do that with the registry program. So the other important part of our innovating is that with all technology, we have to adapt and make sure our system is modern and can support interoperability into the future, and technology changes very rapidly. So our last data platform was fully rebuilt and established in 2015 and 2016, and we've made tweaks along the way. It's what we call the Australian Stroke Data Tool. And last year, or 2003, myself and a team of researchers and clinicians were provided with a research data infrastructure grant. One component of that is to build a modern clinical quality registry platform that can embed a lot more sophisticated reporting tools, but also have additional modules that include clinical decision support and patient information support tools. So these are some of the things that we're working on in the innovation space for registries. And then the other component is to really have a much more routinely embedded way of having the OSCA data also hardwired into national data assets and systems. So in parallel, the Australian Institute of Health and Welfare has been establishing a national health data hub that includes data from hospitals, Medicare, pharmaceutical benefits, and a lot of other sources. It's always changing, and we're going to be one of the first registry programs to include our data, and we're working through, you know, the governance of that. What we're keen to do is that use longer term data, co-design what with clinicians, what information they would like fed back to them, and bring that back into some of the dashboards. And that might be, you know, the timing of that might be less frequent than overnight. It'd probably be an annual update or 3 monthly. We still need to work through that. It also depends on the timing of data getting into the Australian Institute of Health and Welfare. But this is the way of the future, and because it's always about learning from what we're doing and gathering evidence, there is a program evaluation tied to this activity. Both work streams are being evaluated as a collective and as individual entities. So a number of registry-based randomised controlled trials have been conducted, and there are various publications that you can access that go through the detail of this. So this is where, rather than sort of going off and doing your own, you know, recruiting participants and doing a separate clinical trial on a topic, that you build and collaborate with a registry to, you know, work within a real world setting to undertake a comparative effectiveness study. And these can be both prospective or retrospective designs. And it can be an efficient way to recruit subjects, and in conventional RCTs, you might get a much broader or generalisable population, and it can generally be more low cost or pragmatic in terms of the fact that you don't have to wait to identify all your cases that meet certain eligibility criteria. So the other options are that we seek to provide new pragmatic options for large-scale studies and have prospective recruitment of routine patients, so they don't necessarily have to be excluded based on age or comorbidities. I think one of the things to be mindful of is that if you're completely reliant on a registry to give you your data for your trial, the limitations are that it's constrained to the variables that we collect. So sometimes it might mean that you identify patients, you might be able to do your comparisons, or you might have to add in an extra form that needs to be collected. That can only happen if it's a prospective collection. Or you do something like data linkage to enrich the data you've got to answer your question. There's also novel techniques that can emulate RCT by matching patients when you've got very large data sets, but I'm not going to cover that off today, but that could be something for a future webinar. So some practical use cases, if you look at this QR code, we've published examples of prospective recruitment for randomised controlled trials for a range of different projects, and how the Australian Stroke Clinical Registry was able to support that and the types of response rates we got. I'm not going to go through each of them, but you can see we have some really good project exemplars, from quality improvement to studies in the community with people living with chronic stroke. One of those projects that we did where we undertook a cluster randomised controlled step wedge trial was to deliver a quality improvement workshop that we co-designed. It included various workshops with clinicians and barrier identification, and then we provided external facilitator support. And we found that this supported a Plan, Do, Study, Act model where the registry then was able to be accessed to look at how each of those hospitals was able to, shift their practice based on this. So this is just an example, but Bola will be going through one in much more detail around the QUAST study. And here's another example of a registry-based RCT design where OSCAR finds the patient, sends out an e-consent. The hospital-led intervention package was delivered by clinicians, so we could keep them blinded. They weren't aware of who was in the control group from their hospital. And then we could also do the outcome survey by trained outcome assessors from the registry, and then have an independent blinded statistician review the data. So you can actually utilise some of the resources of the registry and also neatly separate and do the blinding. If you want to know how to engage with the registry, Adele Gibbs is the Research and Data Coordinator, and we have a web page under Research that explains how you can access data for research or get or request to survey the cohort or invite them to your research project. So it's a big collaborative effort. It's not driven just by me. These are just some of our PhD students, senior analysts, epidemiologists, and collaborators, including Kelvin Hill there from the Stroke Foundation and Melita Sterling. And together we've been able to provide this beautiful, very extensive national infrastructure that can support learning health systems. So now I'm going to hand over to Bola. Thanks, Bola. Can't hear you.
Sorry, thanks, Dominique. So as part of this presentation, I'll just be focusing more on what works when you're choosing effective implementation strategies for your stroke trials. Dominique, do you want to change the slide? Okay. So just picking up from where Dominique left, this is where implementation science methods come in to address the variability in practice and put evidence-based care into action. So to understand this better, I'll just be breaking it down into simple terms. So we'll refer to the intervention or the practice or the innovation that we want people to adopt as the thing. So when we test whether or not the thing works, that's called effectiveness research. And if it works, the next question becomes, how do we get people or places to actually do the thing? And that's the job of implementation research. And implementation strategies are the specific methods or actions. That's the stuff we do to help people adopt and use the thing in the real world. So when we look at implementation strategies as the stuff we do to help people or places adopt evidence-based practices, we can think about it in two ways. So the first way looks at let it happen. So this is when the evidence is published and it's left for people to use on their own. So there's no real support provided, and unsurprisingly, this often leads to poor uptake. And the second way we can look at this is help it happen. So people are then supported to use the evidence. So implementation is actively planned, and one or more strategies are used to integrate the evidence-based practice into routine care. So this approach is effective for achieving sustainable change. So implementation strategies can either be discrete or multifaceted, and discrete strategies involve a single component, such as training, education, or audit and feedback. But multifaceted strategies combine two or more discrete strategies. And there are several publications that attempt to capture the breadth of these strategies. So for example, Poet et al. Developed a menu of 73 implementation strategies, while Mickey and colleagues created a more granular taxonomy with 93 behavior change strategies, many of which may be used to further specify implementation strategies. Now, the slide on this table highlights some of the commonly used implementation strategies in stroke research, along with evidence of their effectiveness in changing practice. So, for example, the use of local opinion leaders, computer-generated paper reminders, educational outreach, computerized reminders, educational meetings, printed educational materials, and audit and feedback. But one important thing to note is that multiple implementation strategies may be more effective depending on your research question. So with so many implementation strategies available, choosing the most appropriate ones for your stroke trial can obviously be challenging. So what I'll be doing next is I'll be walking you through a real-world case example to show how we approach this process and share some of the lessons we've learned on the way about what works. So I'll be using the Quality in Acute Stroke Care, or the QASC research program, which comprised of 3 large randomized controlled trials and 2 translational research studies. And the QASC research program has improved outcome for stroke patients by reducing death and dependency. So our program of research has been running for more than 15 years and has resulted in significant cost savings to the healthcare system and changes to policy, guidelines, and clinical practice across the globe. So in 2011, we concluded the QASC trial, where we assisted stroke units to implement 3 protocols to manage fever, hyperglycemia, and swallowing difficulties, known as the fever, sugar, swallow, or the FEST protocols. And importantly, data on adherence to these protocols is also captured in the Australian Stroke Clinical Registry, or the OSCA, which Dominique just discussed. So in the QASC trial, we implemented these protocols using a range of evidence-based implementation strategies. So first, we conducted barrier and enabler workshops to assess the local context. And these workshops allowed us to engage with clinicians who were the key stakeholders in this trial and identify the site-specific barriers and enablers to implementing the protocols. So it's important to note that this step, that's looking at doing a barrier and enabler workshop, is crucial because selecting strategies that address context-specific challenges improve the likelihood of implementation success. So after we conducted the barrier and enabler assessment, we held site-based educational outreach meetings, which included both interactive and didactic components. So these sessions provided clinicians with the opportunity to learn more about the protocols and discuss the protocols in depth. And finally, we used reminders, including site visits, email, and phone contact to provide ongoing support throughout the implementation period. So in the QASC trial, we found a 16% reduction in death and disability at 90 days post-stroke for patients. And longer term, there was reduced all-cause mortality with over 20% of patients more likely to be alive 4 years following their stroke. Now, after the QASC trial, we conducted from 2013 to 2016, we conducted the T3, or the TRAJ treatment and transfer trial, which involved translation of the FEST protocols into 26 emergency departments in Australia. However, despite using the same evidence-based implementation strategies as those used in the QUAST trial, there were no improvements in patient outcomes and processes of care in these non-stroke unit settings. So following the T3 trial, we conducted the QUAST Euro project from 2017 to 2021. So the QUAST Euro project was a multi-country, multi-center, pre-test, post-test study to support clinicians to implement the evidence-based protocols. And the study was conducted in the stroke units and services of 64 hospitals in 17 European countries. So we used the same implementation strategy in the QUAST trial, we just adapted it for international use. And the implementation strategy involved audit and feedback, clinical champions, barrier and enabler assessments, educational workshops, and reminders. So for the QUAST Euro project, the results showed significant improvements in overall FEST protocol adherence, as well as the individual fever, hyperglycemia, and swallowing elements of the FEST protocols. And our data suggests that the improvement in FEST protocol adherence was likely driven by our implementation strategy, as other metrics of stroke care quality, such as thrombolysis rates, remained unchanged. So we can see from these three studies, that's the QUAST trial, the T3 trial, and the QUAST Euro project, how important context is when selecting effective implementation strategies for stroke trials. And this has been a key lesson from our work in the QUAST research program as a whole. So although the implementation strategies we use in the QUAST trial and the QUAST Euro project were effective in stroke units and stroke services, they were less successful. Dominique, can you change the slide, please? They were less successful in the emergency department setting of the T3 trial. And we conducted a process evaluation at the end of the T3 trial, and that showed that there were several contextual barriers, such as limited stakeholder engagement, lack of local buy-in, and insufficient leadership support, which all hindered implementation of the FEST protocols in the emergency department setting. The next slide. Yeah. So digging deeper into the issue of context, contextual variation has important implications when selecting implementation strategies, as settings can obviously differ widely at multiple levels. So we can see what is expected at the patient level differs from the provider, organizational, and system level, and vice versa across all the levels. So what this reinforces is the importance of selecting implementation strategies that are tailored to the specific context and the stakeholder needs of your trial setting. So through our work, we've also learned that an important part of choosing effective implementation strategies is to use established theory, frameworks, and/or evidence to guide strategy selection. Next slide. So this table provides an overview of commonly used frameworks to guide implementation strategy selection, including their intended purpose. And I'm sure some of us may be familiar with them. So for example, the CFIR, that's the Consolidated Framework for Implementation Research. And the Theoretical Domains Framework, that's the last one on the slide, which is also commonly used by a lot of researchers, as well as the COM-B, or the Behavior Change Wheel. So in 2009, a group of researchers combined the CFIR and the ERIC tools. So they made it into the CFIR ERIC implementation strategy matching tool. And it was developed as a starting point for researchers when choosing implementation strategies. So this tool provides you with a list of recommended implementation strategies that address barriers that were identified using the CFIR. So essentially, if you use the CFIR as your framework in identifying contextual barriers, then you can then map those barriers automatically using this strategy matching tool to come up with selected implementation strategies that might work in whatever context you're looking at implementing that intervention. But it's recommended that when using the CFIR ERIC matching implementation strategy matching tool, it's recommended that this tool is combined with a more structured approach like intervention mapping to make sure that the implementation strategies fit the local context and support successful implementation. So in the QUAST trial, the selection of implementation strategies was informed by implementation science frameworks. and supported by evidence from the literature, drawing on strategies that had been shown to improve the delivery of evidence-based care. So these are some of the examples of some of the strategies and evidence from the literature we used in the original QUAST trial. So as part of our research program, we're currently conducting, next slide. So as part of our research program, we're currently conducting the QUAST Australasia trial, which aims to evaluate different levels of external remote facilitation to support implementation of the FEST protocols in stroke units and stroke services across Australia and New Zealand. So our multi-component implementation strategy is designed to change clinician behavior to embed the FEST protocols as standard care for all stroke patients. And we're using an integrated knowledge translation model that incorporates evidence-based behavior change implementation strategies and frameworks. Strategies that we're using in the QUAST Australasia trial include an online education package, audit and feedback reports, local clinical champions, barrier and enabler assessments, action plans, reminders, and external remote facilitation. So these implementation strategies are mapped to key frameworks, some of those which I mentioned in the previous slide. So the COM-B, that's the capability, opportunity, motivation model, the behavior change wheel, and the theoretical domains framework. So this table just shows how the implementation strategies that we're currently using in the QUAST Australasia trial align with these frameworks. So another key lesson we've learned when selecting effective implementation strategies is the importance of engaging stakeholders early in your trial to elicit their feedback and make sure the strategies are contextually appropriate and acceptable to end users. And this increases the likelihood that the intervention will be implemented and sustained over time. So evidence from our QUAST research program shows that strong stakeholder engagement contributes to successful FEST protocol implementation. Next slide. So engagement and collaboration between researchers, industry partners, clinician end users, and consumers are central to the governance of the QUAST research program. And the FEST protocols were co-designed with clinician end users, so stroke nurses, physicians, and allied health professionals. And their input has shaped the design and conduct of the research program. So collaboration has also strengthened the relevance and feasibility of implementing the protocols in real-world clinical settings. So in our QUAST Europe study, multi-stakeholder engagement and collaboration were also key to achieving successful outcomes. So a partnership was formed with the QUAST trial researchers, the European Stroke Organization, the European Acute Network Striving for Excellence in Stroke, or the ANGELS Initiative, which is a not-for-profit health organization, and the Registry of Stroke Care Quality, so RESCUE, which is a clinical quality registry. And this partnership fostered international collaboration among researchers, hospital executives, governments, professional societies, and industry in high and middle income countries. And this resulted in successful, rapid implementation and scale up of the FEST protocols into countries with vastly different healthcare systems, and demonstrated on a large scale what can be achieved when healthcare and industry commit to a shared vision of improving stroke outcomes. So our ongoing QUAST Australasia trial, which is currently being undertaken in both Australia and New Zealand, also highlights the importance of engaging and collaborating with key stakeholders, particularly the Australian Stroke Clinical Registry and the Stroke Foundation, who have both been involved from planning through to implementation, with ongoing roles to support sustainability of the FEST protocols. Their contributions have been critical to trial design, recruitment, and data collection via the Australian Stroke Data Tool, or the AUSDAT, enhancing the overall conduct of the trial. So as part of this trial, we also plan to undertake an economic evaluation, and this is only made possible through our collaboration with the Australian Stroke Clinical Registry. So to conclude, these are just some key take-home messages. So selecting implementation strategies can obviously be challenging, and there's no single best strategy. So it's not a one-size-fits-all approach. It's important to remember that context is key, as context is key to the success of implementing any intervention, as the success of a strategy depends on how well it fits that specific setting. It's also important to use established theories, frameworks, and or empirical evidence to guide your choice of implementation strategy, and engage stakeholders early, as collaboration is essential for successful implementation. So hopefully this has given you some practical insights and ideas for choosing strategies that support successful implementation in your own stroke research.
So there's a list of references there which we're happy to share, and also we have the various main references if you're interested in anything that I presented or from Bola. But I'll now hand over to Liz to facilitate some question and answers, and we're really keen for some ECRs or EMCRs who we've targeted this talk to from the CRE to ask some questions as well.
Great. So if you can pop your hands up if you've got a question or in the chat, but in the meantime, I'll kick off as I'm still an MCR with a question for Bola. The Quask Europe project, I noticed it went from very, very low to 34%, I think, adherence with recommendations. So that's still quite low. Is that project, like, do you then have to, are there plans to keep working on that? Do you need to adjust the strategies? Because obviously if you're not doing it at all, you're doing it kind of, that you imagine you'd need to adjust your strategies. What are the plans to keep working on that? Or are there plans?
Not at the moment, to go back again and re-audit and check, you know, obviously the adherence levels of the FES protocols since conclusion of the Quask Euro project. But it is likely that, you know, maybe the strategies might need to be tweaked in one way or the other to improve implementation of protocols. It was a really large study, like we said, in 17 countries. So, and you know, with very different health systems, we do still believe that, you know, having that difference from 3.4 to 35% is still a reasonable improvement. But hopefully, you know, we are working, I know Sandy is still working with some of the countries, you know, and I guess the main thing is just trying to get them to actually make it get the protocols embedded within some of their own stroke guidelines and some of their local policies. I know Sandy has just put a comment in the chat, but there's a rescue, because with the Quask Euro project, it was the Registry of Stroke Care Quality that they used to collect the data, and the FET variables are now included for routine collection within that registry. So hopefully hospitals are able to go back when they collect the data and audit their practice and see, you know, in terms of room for improvement.
I'd still point out that that is still a large effect size for these types of intervention studies undertaken in the real world. So if you had looked at the, sorry, everyone's going to go blind, this audit and feedback alone only has a shift of about 2.7%. So yes, in terms of the FES protocols needing to be delivered to more people, in the context of those European countries, they had been delivering very, I guess, poor quality of care overall, and they're in a capacity building phase. So it was a massive achievement for a very complex study to reach that type of effect size. When we did the Stella project within the context of Victoria, we got a large effect size that we were pretty happy about, of a net difference of 17% in practice. So I think part of, and I don't know, Sandy might want to comment, but where the audit and feedback laboratories that are focusing now is not, you know, sort of head-to-head studies in this space. It's more about how we optimise and build on the components and use evidence. And as I said, it's like registry science here. This is where it's all meshing together about what tools, what types of reminders, computerised otherwise, you know, how do we design our dashboards? How do we use nudge factors or clinical opinion leaders, different forms of facilitation to drive up and improve our toolkit here. I don't know, Sandy, if you wanted to comment. No. So I'll stop sharing and hand back to Liz and see if anyone out. Oh, okay.
Yeah,
Sandy can't unmute, so I hope I did it justice.
We've got a question from Tashna from Monash. Thank you very much for your presentation on your clinician-focused implementation strategies. Do either of you have any advice on strategies to optimise uptake or adherence among patients?
Well, you would use a similar approach. It's just a different audience. So, Bola, do you have suggestions?
Yeah, I was thinking more about, like, with the Quasc Australasia trial, which is currently ongoing. Like, one of the strategies we're trying to use to optimize uptake or adherence directed at the clinicians in this instance is more around the remote facilitation or external remote facilitation, which is really what we're evaluating in this trial. So not when you're looking at optimizing the uptake, what we're doing is we're supporting clinicians, trying to build their capacity and just improve that implementation eventually, when it comes to their implementing the first protocols for patients. So I guess, like Dominique said, is really what, we've talked about, audits and feedback. I guess, monitoring your practice, seeing what's there. You audit, you can see that, okay, we're not really adhering to the protocols like we should when we're looking after patients, and going back and seeing how we can improve practice. Is it, what are the barriers? Doing that barrier and enabler assessment as well as an implementation strategy. What are the barriers? Are there any contextual barriers that we need to be overcoming or addressing in terms of helping us implement the protocols?
And in terms of something that would involve the patient, I might put back on Liz, because she's an expert in self-efficacy and self-management and co-design with patients and caregivers. But if it's a problem around adherence to medications, for example, you need to know from the patient perspective what's driving that. Is it they can't afford it? Is it that there are the medications they're on might disagree with them, they have side effects? So the same frameworks can be used. It's just the target of the improvement topic. So Liz, do you want to just maybe outline, like when you're working with patients and caregivers, the importance of understanding that context?
Yeah, thanks, Dom. I think that was what I was thinking, like exactly what you both have said. It's the same concept, but you do come at it with a different angle. If you're working with health professionals have a particular way of thinking, they have a particular knowledge base, and if you're working with people with lived experience, they obviously have various levels of health literacy, but really understanding what the real barrier is. I think very often we assume too much when we don't listen enough. So I think really going into when you're doing the barrier assessment is going in with a really open mind, because quite often there are things that we didn't consider. For instance, people don't take their meds because they're expensive and they're poor, things like that. You're thinking, well, that's a real problem for adherence if people are having to choose between fresh veggies and a really expensive medication. Or it might be that they don't understand the point of the medication, or it might be something really different. So it's about really taking the time to understand the barrier and then working with people to come up with solutions that work for them. Because I think that from the more work I do where we're involving people with lived experience, we are coming up with way more creative strategies than I would have used to when I was way more health professional mode directive.
Yes, very good points.
We've got a question in the Q&A from Dawn Simpson. She's thinking about budgeting well for implementation projects. Do you have advice about costs we should budget for around implementation strategies that we might not initially think about?
I think this is a tough question when you're writing grants, like, have you covered yourself well enough? Have you considered how long it actually takes? So I know when we did the Stella project, it took a lot longer because we also had to wait for when the hospitals were ready for us to deliver intervention. And then you need to determine whether you can do it as effectively through a low cost approach or one that might mean it's in person. So really thinking through, I guess, you know, each configuration of what you might deliver and what the cost, and getting quotes ahead of time. So if you're having to print glossy materials or you're having to do in-person visits, you need to account for the travel, and depends on where your sites will be. You need to speak to sites if they're part of a trial, you know, understanding what costs they might want if they're recruiting people, or if you're having to buy out clinician time, what are those costs? So there's a lot of planning that needs to go into all your budget items, and getting that information pretty well sorted before you go into a grant, and then also ensuring that some of those key people that are going to be responsible for budget or delivering budget or providing resource are part of your grant, so that later on you can come back and say, well, you know, we had agreed on this was the grant budget. I think there's another comment from, was that the comments in the Q&A are on different pages, sorry.
Yeah, so the comment in the Q&A is, the comment in the chat is about audit and feedback. There is evidence that the mechanism of feedback is important, from Simeon.
Yeah, so if you're wanting to implement a new digital tool, you have to understand how to do that. For example, within our stroke registry, if we implement a new dashboard, at the moment, it sits with the Amazon Web Services hold the software. So we do these in QuickSight. So there's the licenses to develop the dashboards, and then you might need people to feedback, so you might need to allow for some sitting fees. But then in terms of the registry covering its costs, especially for these types of studies, if you had a particular thing that you wanted to deliver, we would have to consider what the costs are to administer that. So, for example, if there was a particular dashboard, we also get charged per view of that dashboard. So, you know, sometimes there is estimating, but it is important to think through all the different components of what you need, who is involved in delivering the resource, and having those conversations early about, will it fit to my budget? And I know, for example, there might be some Stroke Foundation C grants out there, and you might have a really great idea, but there is no way, unless you get in-kind support or support from your university or organisation, to cover the gap if it's something that has is resource intensive in terms of what you want to deliver. Not sure if there's other people online that are doing these types of studies, like Sharon. I can see Sharon and Christine. Did you want to make comments, or how you do your budgeting, or things that you consider for your projects? Putting you on the spot. Or Liz. Oh, here comes Sharon.
I can't really comment on budget because it's not my budget, but yeah, I do agree with, if I think about how big the trial is that I'm sort of managing, it's I think the point of you saying all the sites that are involved and making sure that the expectations about what is going to be covered is essential. And as you say, that needs to be sort of covered early in your sort of design and budgeting for the project. Yeah, so I'm just confirming what you already said, but that's I think that's a really important point
And
to consider.
Caleb is also online and he's developed a few digital tools. So I just wonder if, Caleb, you want to comment on things that you've, maybe even some lessons you've learnt from going through this process.
Just in terms of budget, Dom?
Well, anything we've discussed, but also thinking about planning your grants and, you know, the types of things you have to consider, or even the, you know, the amount of time it can take for the development of new tools, even when you're doing co-design.
Yeah, I think leaving adequate planning and adequate time for all of that as well, and really carefully thinking through some of the costs that are involved. Even myself and Sandy have, you know, there's quite a lot of changes in New South Wales with regards to site costs for ethics and governance, for example. So if you're doing multi-site studies, really factoring in some of those costs, the grants around governance approval at the moment, particularly in New South Wales, is an issue. But yeah, I think allowing a lot of time around the co-design phases, if you want to do them properly as well. And I guess it's the different level of engagement around some of the co-design processes and methods that you might use, and I guess the level of engagement that you want with consumers and people with lived experience around, is it sort of consultation and involvement, or is it really authentic partnership in the co-development and co-design? So it's really sort of carefully thinking through some of those issues. And yeah, I think that building in, I often thought that sort of planning a timeline was a bit of a redundant exercise, or a boring exercise, I should say. But I think, you know, really carefully planning out your timeline and thinking about all of those individual activities is really super important. Yeah.
And Liz, your recent project, did you have things that blew out, like some lessons learnt from you that you might want to share with our audience?
Yeah, everything takes way longer than what you think. Participant recruitment takes way longer than you think. I was going to say, in terms of the implementation costs, I think taking, like Caleb stole my thunder, I think, is taking the time to establish relationships that work. Like, I think you often go in and you get along with people and everyone agrees, but to then move to that working relationship with new teams, it actually does take a little while to get that deeper level of understanding where everyone's working really cohesively together. And when you are, like, I've done a couple of projects where we've employed staff within the unit to be might be a site champion, or it might be someone who's collecting data for the project or whatever. So they have a dual role, but will buy out their clinic time to do research. And you have to, I think one thing that I've learned is you have to be super strict with, if someone is sick that day, what's going to happen? Do they give up their research day to do clinic time and drop your research? And that tends to be what happens, because people's first focus is on patient care, which I get. But when it's on your budget, that really sucks. So having those really very overt conversations about how to manage that sort of stuff is something I've probably learned that is important to do budget-wise.
Yeah, and it affects your timelines as well. So I think what you're also alluding to is the fact that allow more time for things in your timelines and be realistic. So sometimes people want to put together a really fancy project that has everything in it, but what might really be achievable in a one-year project is a co-design with some initial early pilot testing before you can take it into the next stage of you know, putting it in within a health service environment, or in a randomized controlled trial. So working through all of that. If anyone else wants to put their hand up or make a comment. Anything else from you, Liz? Like your reflections on using all these tools? It can be rather mind-boggling. There's so many choices.
My second question for Bola, we probably don't actually have time, was about the C for Eric implementation matching tool. So I haven't used that. I was just wondering if you have used it, and is you know, certainly some people love CIFA for coding and some people find it overwhelming. And to then match it with Eric, I was like, oh, that could be a world of pain, or it could be amazing. I was just wondering if you've used it and what your experience was.
No, unfortunately, I haven't used it. Yeah, but the evidence says that you know, it's just new. People haven't really, like, you know, started using it, and they're hoping to see more research around its use. But I haven't even seen any papers that have been published that have actually used it. But they did clearly say that if you do choose to use it, you should combine it with other implementation strategy selection approaches like intervention mapping, and don't just use it randomly. Just have to be sure. Yeah.
Okay, thanks.
Okay, well, there are no further questions or comments.
So many thanks to Bola and Dominique for a great session, and thanks for the interaction from the crowd, for your questions and your comments and your feedback. That will be the end of the session.
Enjoy the rest of your
this is
day.
recorded, isn't it? So it is recorded, I think, isn't it? So
yeah,
people can watch it back if they need.
And